Perfect. All right. I am so excited to be here today and discuss HIV and pregnancy, and how we can support our patients from preconception through postpartum. So I will just do an overview of how HIV can impact pregnancy and then kind of throughout the peripartum period, or from preconception through postpartum, discuss, what we do for women living with HIV. And then we'll have some case presentations and I have some tools at the end that I'll share. So first, how HIV affects reproductive health in general. Women living with HIV have unique concerns as far as family planning and kind of figuring out their pregnancy intentions and discussing contraception and what that means with regards to their treatment. They're also at an increased risk of subfertility and infertility, both female and male factor, which can affect their family planning and pregnancy intentions. And then when inside pregnancy, there's unique maternal and fetal risks, which we'll really focus on today. Certainly the risk of vertical transmission to their baby, and then postpartum considerations as well. In looking at the most recent data for the United States, you can see that there are 66%, so two-thirds of all new infections are actually among reproductive age women. And the majority of these are due to heterosexual transmission. And then thinking about our HIV prevalence in a country as a whole, that's more than 77,000 women who are of reproductive age. And so certainly pregnancy becomes a large part of what we discuss with women living with HIV. Where it kind of meets obstetrics. So we have women who are HIV negative, so seronegative patients who have HIV positive partners. And more than half of these couples desire to have children. And so these women may be at risk for acquiring HIV within their pregnancy. Of women living with HIV, about 40% from studies show that they desire to have children. And then almost, 10 to 30%, so one in every four, almost one in every three pregnancies affected by HIV are actually women who are diagnosed in pregnancy. So it becomes a really unique and important time given our routine screening where we can diagnose women, and hopefully with prenatal care we can do that early and help them achieve viral suppression. But all of this results in about 5,000 births to women living with HIV annually. As far as transmission risks in pregnancy, so this is kind of thinking about those HIV seronegative women who may have a seropositive partner. Risk of transmission actually goes up in pregnancy. And so a lot of this is related to the hormonal changes. You get a shift in your immune response to a more innate immune response. Certainly risk of inflammation. And so your risk of HIV transmission goes up with each trimester. And then is highest actually in that postpartum period. And so you can see these charts on this side just showing kind of what our HIV risk is, and particularly related to their sexual frequency and the HIV viral load of their male partner. So all of that kind of increasing the risk of transmission for these women. And then with acute infection in pregnancy, the risk of vertical transmission is actually 8 times higher. And so trying to prevent infection in pregnancy, because that does increase the risk of the baby being born with HIV, as well as kind of addressing the postpartum period where you have the highest risk of transmission. And then if a woman is breastfeeding, there's elevated risk of vertical transmission as well. So this is kind of looking at where we've been with perinatal transmission, and just, I think, profoundly shows in these charts down here in the corner how prior to the use of zidovudine or AZT, we had these high rates of maternal to child transmission. And then with the use of intrapartum followed by kind of antenatal antiretroviral use, we've actually had really a ton of success in decreasing transmission to our babies. And so the most recent data that we have from surveillance studies is from 2019, showing 32 cases of perinatal HIV transmission. And the bulk of these are due to patients who just didn't know their HIV status prior to pregnancy, and probably, either presented with acute infection or limited prenatal care and didn't have access to antiretroviral therapy, because we know that the bulk of women living with HIV who are diagnosed, even if they're diagnosed in early pregnancy, are receiving antiretroviral therapy. Vertical transmission risk kind of depends on the period of pregnancy that you're in. So in the antepartum period, the virus can pass through the placenta and cause a fetal infection. There's increased risk then with trauma and disruption in that maternal fetal barrier with the placenta, so like a placental abruption. But it's about a 5 to 10% risk of transmission without antiretroviral therapy. And this is about a third of all vertical cases. The highest risk is really in the intrapartum period. And so there's been some data to show maybe prolonged rupture of membranes then increases exposure to maternal secretions. Again, the risk of placental disruption, so abruptions and things that happen in labor. And then with delivery, that's about a 15 to 20% risk in the absence of antiretroviral therapy, but accounts for 2/3 of vertical transmission cases. And then certainly in the breastfeeding period, we don't have tons of data because historically women have been instructed to not breastfeed if they're HIV positive, but the risk of transmission is about 20%. So this slide just kind of shows how all of that can be prevented. And this is an old study from 1996, really. Shortly after zidovudine became available and trials were showing, or this is the trial that showed that giving zidovudine can decrease perinatal transmission. And the two things that are important here are that HIV transmission to the baby is really related to viral load. So in very, very high viral loads, it's greater than 80,000, which we see in acute infections. There's like 100% transmission, and even some of those, so the part it's on my left, those like open dots, those are the patients that actually received intrapartum zidovudine, and there's still some transmission, so it's not perfect. But if you look for the non-transmitters, you can see that zidovudine does significantly decrease HIV risk, and having a lower viral load does that as well. This is another one of those seminal studies that kind of looks at using zidovudine during pregnancy, so antenatal use of antiretroviral therapies, and how that affects HIV transmission. And again, it's really due to decreasing that HIV viral load, but significantly, impacts vertical transmission by offering antiretroviral therapy and thus reducing the viral load. And then we get into how we arrived at elective C-sections for prevention of vertical transmission. This is again looking at zidovudine use during pregnancy, either yes or no, and then how it relates to delivery method. And you can see that cesarean delivery in general reduce the risk of perinatal transmission. So our odds ratio without zidovudine, 0.3, just hitting the 1 mark for significance, and then in the presence of zidovudine down to 0.6, but again, not significant. But based on this data, they kind of decided, okay, if your viral load is elevated, and even though they don't present viral load information here, a C-section can be protective against vertical transmission of HIV. So I just want to talk, before I move into treatment, a little bit about how we're addressing or how antiretrovirals work, because we have a lot of different mechanisms and how HIV reacts with human cells to then target with our pharmacologic agents. And so The big ones that we're using, are NRTIs. This is over here with the cytoplasmic transport. These are preventing the reverse transcriptase from turning the HIV RNA into HIV DNA. And then the INSTIs over here in the integration, those are integrase inhibitors preventing the DNA that has been created by the reverse transcriptase from integrating into host DNA. And then protease inhibitors, which are kind of preventing the proteins that are used for binding to other human cells. And so that would be important for infecting future cells and kind of the propagation of the infection. So we'll use protease inhibitors pretty frequently as well. I think those are the big classes. Our NNRTIs are non-nucleosidal. They're kind of adjacent, and we do use those occasionally. But basically, we prefer to use a combination of 3 different types of medications, or three different medications, often 2 NRTIs, and then 1 integrase inhibitor or protease inhibitor. But if somebody is very well controlled on their pre-pregnancy regimen, we can continue them through that. With all antiretrovirals that have been studied, there's a pretty low risk of teratogenicity. Some of that is data that's a little mixed, but in general, we feel like antiretrovirals are really safe in pregnancy. And really the recommendation to not use certain medications is due to just pharmacokinetic changes in pregnancy. So we're thinking about preconception care. We want to make sure that they're on a good antiretroviral regimen, evaluating for any side effects of the antiretrovirals. And then the goal would really be to have an undetectable viral load. Here at NUSC, that's less than 20. A lot of places it's less than 50, but certainly we want to see viral suppression. So a viral load less than 200 for at least 3 months. And then catching them up on routine preventative care, optimizing comorbidities, and then making sure they're on a prenatal vitamin with folic acid. And that folic acid becomes more important if they're on opportunistic infection prophylaxis with a CD4 count less than 200. Antenatally, so everyone needs to be on a multi-drug regimen, meaning multiple types of antiretrovirals, but could be a single tablet. And then you want to make sure that you're coordinating care with a primary HIV provider, that somebody is there who is capable of kind of monitoring viral loads and side effects of the antiretrovirals. If it's a new diagnosis or they're not on treatment, they should be initiated immediately or as quickly as possible. And we want to get drug resistance and plus or minus this HLA-B 570 to kind of help guide that regimen. But again, pregnancy, lactation, attempting to conceive should not keep someone from being on a certain drug regimen, especially if there's, benefit and if they're well sustained on it. This website is incredibly helpful. So I mentioned it. I don't want to spend a lot of time on this because I think it's a little bit in the weeds, but essentially preferred regimens are, again, 2 nucleoside reverse transcription inhibitors, the NRTIs. That's something like Truvada and Descovy, which people probably have heard, which are both 2-drug tablets. And then an integrase inhibitor, which has bictegravir and Biktarvy, so that's a single tablet regimen that has everything you need. Or we'll do Truvada or Descovy, and then Tivicay, which is dolutegravir, your integrase inhibitor. If somebody has been on an injectable, like cabotegravir, which is an integrase inhibitor, then we would want to, if we don't know if they have resistance to integrase inhibitors, we would then put them on a protease inhibitor. And so they would be on something like darunavir, boosted with ritonavir, and then on 2 NRTI, so either Truvada or Descovy. Things that are not recommended are over here, and this is really, again, pharmacokinetic wise. And I want to point out this long-acting injectable. So Cabenuva is cabotegravir with rilpivirine, and we have a lot of people who are doing really well on it. It's an injection every 2 months. We see great rates of viral suppression with it, but there's really limited data in pregnancy. And just last month, data came out. It's 2 case studies, but really one of them was looking at cabotegravir injection or Cabenuva injection every 2 months in patient A. And then in patient B, they did Cabenuva injection monthly. And they saw that even though cabotegravir concentrations were acceptable, when they're down here, it's because they switched patient A from cabotegravir back to Biktarvy. The rilpivirine concentrations, so rilpivirine is kind of like a wimpy NNRTI, and so rilpivirine concentrations were lower, and it's really not recommended to have somebody essentially on one functional medication. There's a good risk of kind of breakthrough and getting a viral load increase. And so changing the Cabenuva injection from 2 months to 1 month actually gave us therapeutic drug loads. And so I think we probably will see Cabenuva just with a modified dosing schedule in pregnancy. You want to know about these patients' HIV-related history, prior or current regimens that they've been on, side effects, barriers to adherence. If they have a history of opportunistic infections, I think this becomes pretty important with like toxoplasmosis and thinking about reactivation with immune suppression, and then putting them on opportunistic infection prophylaxis until their CD4 count is greater than 200. And we typically do that just with daily Bactrim. At an initial OB visit, we want a CD4 count and a viral load. If their viral load is undetectable, then we'll just repeat viral loads only for every 3 months. And then just make sure that we get one 4 weeks before delivery, usually at that 34 to 36 week mark. If it's detectable, you want to repeat it monthly until it's undetectable twice. And then you can go to that every 3 months and then right before delivery. Again, CD4 count, if it's less than 200, those can take a little bit of time to rise. Or if you have concerns for viremia, they have, failed their regimen and now have a detectable viral load, I would repeat the CD4 count and then every 3 months until it's normal. And then if they have a normal CD4 count, they've been on antiretrovirals, everything looks good, you don't really need to repeat it again. And then if you do pick up resistance or if they're changing their antiretroviral regimen in pregnancy, you do want to check their viral load every 2 to 4 weeks. In thinking about obstetric risk, so we know that these patients often come with kind of complex medical histories. So they may have pre-existing chronic comorbid conditions. And this paper kind of reviews that women with HIV are more likely to have a chronic condition in pregnancy. However, there does not seem to be a statistically significant increase in obstetric complications. Other data has shown slightly increased risk at preterm birth, growth restriction or low birth weight infants, and preeclampsia. This study personally kind of did not find those things, but just because there is a correlation with some antiretrovirals and HIV in general, we tend to do growth scans in our 3rd trimester just to monitor fetal growth. With delivery planning, we discuss, we'll get a viral load 4 weeks prior to delivery. We do that 34 to 36 weeks, but tend to have kind of an understanding of viral suppression and where our patients are going to go before that. If their viral load is greater than 1,000, we recommend a C-section. Certainly, you can't force someone to have a surgery. And so I would, if somebody is adamant that they want a vaginal delivery and they have viremia, have an induction scheduled and begin zidovudine, although strongly recommend a C-section. But with viral loads less than 1,000, these patients are candidates for vaginal delivery with no other obstetric indication. The perinatal transmission rates are low, and having a C-section does not change that. And risk of vertical transmission is low as well. So in our patients with an undetectable viral load, that's less than 1%. And if they do have a low but detectable viral load, it would be about 1 to 2%. As far as people who don't need zidovudine for kind of that intrapartum prophylaxis, I would say those are women who are definitely getting antiretroviral therapy, no concerns for adherence, and then have that undetectable viral load pregestationally. There's pretty limited benefit. I'm almost done, so I'm going to take a couple extra minutes. Limited benefit to zidovudine with that detectable viral load. So some institutions will offer shared decision making, but the data on zidovudine is both with IV and with oral. And if you have somebody on antiretroviral therapy and they're taking it orally throughout their intrapartum course, which we recommend, I don't know that there's really clear additional benefit to having them on IV zidovudine, especially when the medications that we have, like something like Biktarvy, is, I think, better than AZT. And then neonatologists are involved, infant treatment, and then people are candidate for breastfeeding if they have undetectable viral loads and are adherent to their medications. Intrapartum, if you have somebody just like roll into labor and delivery, you don't know their status, they don't have prenatal care, a rapid HIV test can be life-changing for a baby. And so as long as it's safe to wait for those results, I would get the rapid HIV test, and if it's positive, start zidovudine immediately without waiting for confirmatory testing, and then determine a delivery plan. So if they need a C-section, giving them 3 hours of zidovudine pre-procedure, and then certainly continuing oral regimens intrapartum and letting your PEDS team know. There's really limited data, I think, or newer data to kind of suggest. So I think theoretically, any kind of break in fetal tissue is going to expose the baby more profoundly to maternal blood, maternal secretions. However, with viral suppression, especially in the era where we have like such small levels of viremia that are detectable or no viremia detectable at all, I think that, it's hard to know what that risk is. And so the historic kind of teaching is don't break water, try to avoid scalp electrodes, try to avoid operative vaginal deliveries. And we have newer data that shows that, prolonged rupture of membranes with viral suppression really doesn't increase the risk of transmission. I would just kind of weigh the risk and benefit with obstetric indications for a scalp electrode or an operative vaginal delivery, and kind of with concern for that. And then if people are on protease inhibitors or cobicistat is not necessarily recommended. It's like a booster that can be available. We should avoid methergin for uterotonics. And then they may not work as well if you're on like an NNRTI, but these again are not very commonly used. Thinking postpartum, so all babies are going to get some sort of post-exposure prophylaxis, and that ideally occurs 6 to 12 hours of life. And then they follow up with PEDS ID to get viral loads within 4 weeks of delivery, and just kind of evaluating how they're doing. There are new guidelines on breastfeeding that were updated in 2023 that show that the risk of HIV transmission through breastfeeding in somebody with an undetectable viral load is about 1%. We don't, again, have like great data on this. And I think there was like some issues on arriving in consensus. And so really it's kind of a shared decision-making recommendation, but there's no consensus on what do we treat the infant with, how long do we treat them, how long do we recommend breastfeeding, and what does that monitoring look like? And so kind of having the discussion with your patients about the risk of HIV transmission compared to the benefits of breastfeeding, which we know are many. And then the approach that we use here is with viral suppression, we recommend, we offer the option to breastfeed. They follow closely with our PEDS ID team. We do monthly maternal viral loads and breast checks. And then the baby also has routine monitoring and is on a 2-drug regimen throughout the duration of breastfeeding, while the mother continues her oral antiretroviral, and then they kind of continue treatment after weaning as well for the infant. Okay, that's all my